Good morning. My name is Sharon Cohen. I'm on faculty with the Department of Gerontology, and it's been my great pleasure to be teaching our course on death and dying for the last couple of years. And this year we actually did something experimental, and we invited in some 55 plus continuing education students, and I see a lot of them here. So, hello. One of the things that really becomes very apparent when you're teaching a course like Death and Dying is that the experience is very different for everybody, as Kelly has so eloquently pointed out already. And one of the things that really comes up as critical is a person's sense of identity or personhood. And that differs considerably across cultures and also for gender and sexual minorities. Another thing that's very important as well is a person's religion, because that teaches us how to live while we're alive, and then it points out consequences for how you did that after death. So that final experience of death and dying is rooted in personhood, in religion, and then over our life course, what we learn, and often what we learn as professionals. So we put a lot of effort today into ensuring that experiences that may differ from the norm are represented in this conference so that our innovations can address those differences. For example, very briefly, you saw how palliative care is rooted in a Northern European and North American tradition and Christian religion, right? And so that isn't necessarily consistent with the sense of identity and the personhood and the religions of people who immigrate here from other countries. So we have a very interesting and diverse panel across many different cross-cutting identities today. I'm very excited to present to you, and I'm going to introduce them all at once and expect you to look in your bios for more information. But we have on my right, this is the order they're going to speak in. So on my right we have Jazz Chima, who has spent a lot of her life working as a diversity coordinator. Next we have Dr. Akbar Mithani, who is a physician who works with geriatric populations at Providence Healthcare. Next up we have Joyce Swong, who is a researcher who's been working with iPanel with Kelly, and also in a Providence site where she's been talking to patients about their experiences of end of life. And Felicia Wong to her right is also a nurse for Providence Healthcare, and she's going to share as well from a practitioner's perspective what the end-of-life experience is like. And finally, Dr. Gloria Gutman is going to speak to the experiences of gender and sexual minorities, something that she and her colleagues have been doing a great deal of work on lately. So with no further ado, we will proceed with our panel. We're going to give each of them 5 minutes afterwards, but because of the joint nature of their presentations, Joyce and Felicia are going to field questions when both of them have spoken. Okay, so I'm going to let Jazz take the floor.
Thank you, Sharon. Good morning, everyone. So I'm really pleased to be here today, and I want to say thank you to Sharon for inviting me to present today. With the growing diversity in our community, I think it's really important that we look for new and innovative ways of how we're going to address the diversity in our patient population. So today's presentation, what I wanted to go over was not just South Asian aspects, but just generally, how do we address diversity and look at people as individuals versus groups of people like South Asians or Muslims or Chinese. So I wanted to just discuss some basic principles around cross-cultural communication. And then I'll tell you a little bit about my own experiences of working with the South Asian community, which is our largest community. I worked for Fraser Health for a number of years. And the largest population in our region, in Surrey and Abbotsford, is Punjabi Sikh population. And I'll just talk about my experiences of working with them at end of life. So when we're talking about generally how do we interact with people that are quote unquote different from us? What we might notice in this iceberg model is that we really see the person's body language. We might see it, whether they're making eye contact or they're not making eye contact. What their foods are. Like South Asians are known for butter chicken and samosas, and so, but what does all of that mean, right? But and not all South Asians eat that food, right? And so what does it all mean? So what is their notions of modesty, or what are the concepts of beauty or privacy? Those are the things that are kind of hidden, and unless you're really able to ask those open-ended questions and really get to know the person, you're not able to just walk into the room and just kind of know what is it that this patient needs. So just, being aware of that. So some of the stumbling blocks that we all face is our own assumption of similarities. So, you see Jazz, she's dressed in her Western clothes, and then, you might assume that, she's very Western in her ways, she can speak fluent English, but then, I might have lots of values that are similar to yours, but there would be values that are very, maybe even opposite to whatever it is that you believe in. So it's our assumption that, a smile means they're happy or they're agreeing with what I'm saying. I always get teased because whenever I say yes, I kind of go yes, right? And so, so we all have our different habits, and they could be, you can judge people negatively or positively based on that. And also misinterpreting nonverbal cues, so what I just said. So I have a little nephew at home, and he doesn't speak any Punjabi. My grandma speaks Punjabi, and so he's running around, and she's getting mad at him, like, you shouldn't be running around and you're going to get hurt. And so he's not really understanding what she's saying. He does what little kids do, right? And so then all of a sudden, Grandma gets up and she's really mad, and she gets up there and she goes, "Oh, I'm going to hit you one if you don't stop," right? And he so innocently kind of just looks up and kind of sees this and kind of goes, "High five, Grandma," and he goes running around again, right? Because that's all he knows, right? So again, we can misinterpret what somebody might be, saying to us, right? Our own stereotypes and biases, and that's a huge one, because I think we all have them. Me as a diversity consultant, I have my own stereotypes and biases. It's not about getting rid of them all, because it's also how we make sense of the world, but it's about knowing them and being open to having those challenged, and our tendency to evaluate based on our own understanding of a different culture. So that's why when I do diversity training, I don't really believe in actually talking about a certain culture as all of the people in that culture are going to act in a certain way. Because then we're going to go in there and go, Joe Jazz said, all South Asians or all Sikhs are going to do this, and this one doesn't, because we're all individuals, right? And it's really up to us how we, based on our education, our experiences, how much of our faith that we actually incorporate into our lives, how much of our culture we incorporate into our life. When we're in the medical system, especially at the end of life, there's a lot of anxiety. And so when we're going into these situations, our tendency to be misunderstood is a lot higher than, hopefully here, you're open to asking questions and clarifying things. So some of the solutions to all that is just being aware of the blocks and overcoming them, developing empathy for others, and learning about nonverbal cues, asking questions to clarify stereotypes, and of course learning about other cultures. So when we look at the fabric of Canada, 75% of our population is that of visible minorities here in the Lower Mainland. And so 25% of BC's population is that of visible minorities, and our two largest groups are South Asian and Chinese. And then, as we hear in the news and everything, there are more and more immigrant groups that are coming into our communities every day. So when we talk about South Asians, there's many different generations that are here, and most of the earlier settlers came from the Punjab, and then there were waves of other groups that came in. The ones that are coming in now, the foreign trained workers, are coming from anywhere from India. Some of the things that are very diverse in them is the language and educational backgrounds. So the earlier settlers had little English skills, little education. A lot of them were illiterate, but again, nowadays university education, English is their first language, never mind second language. Their context of what, so how they've culturalized. So there's about 4 generations here now. So again, each of them are very different. And then they also have their own reference point of what the healthcare system was in the old country, and there's a lot of mistrust of the medical system. They're used to private pay, because in India, if you want to get service, you pay, you get it. And there's intergenerational differences, and so that's why it's really important to ask those open-ended questions so you actually connect with the individual versus a cultural group. So some of the largest groups that are here in the Lower Mainland, the faith groups is the Sikhs by far, they're the largest. We've got the Hindus, we've got the Ismaili group, and then the Pakistani Muslims. So some of the things around end of life, there's a fear of being a burden, not understanding the death and dying process. The things I've seen is also their belief that, you don't want to tell the patient of what they're going through, what the outcomes are, so because they'll lose hope. A strong belief in the higher, and so there's beliefs around the disease process and sickness and how that's related to karma and not really in their hands. Guilt is a big one, because you know what, I've lived a good life this time, why am I being burdened with this disease? Most of them have a belief in life after death, but not all. And then there's, again, the meaning of pain and suffering is all, what I've noticed is related to how much they have a belief in the higher. So again, all of those things, each family or each individual will be different, and depending on how much, what their belief system's like. Some of the other issues I've faced is language barriers. So using interpreters. Most of the health authorities now have interpreters and translated material available. Just a caution on the translated material, not translating word for word, but making sure it's culturally appropriate. Education about end-of-life issues, the policies, the interventions that we have, and the healthcare system. I mean, I know that's the same for everyone, but particularly if you're new to the country, the whole system is so confusing. Work in partnership with the family members, and again, trying to find someone who will be the spokesperson, because they can have large families, and everyone wants to be the decision maker. And allow space for customs, beliefs, rituals around end of death. What I've noticed is a lot of the Sikh families will want to pray at the bedside, or they have a tape that's playing at the bedside. Just allowing for that, because that's what brings them peace. And then understanding some of the mourning rituals, grief and bereavement practices is also very important. I've seen nurses or our staff get really taken aback when there's wailing, or large groups will come in. And again, but this is how this group expresses grief, is to be together, and that families, large families coming is just a normal way of them doing things. I'm actually following a patient right now, and they're never alone. There's always somebody there, and they're always praying. And the nurse said to them, well, there's just too many people coming in here. And it was really sad to see that, because this is what gives that patient comfort, is seeing that, that their life was meaningful, and all these people are coming to visit and to be with him. And so, in closing, I just have given you some recommendations around how to make your services more culturally appropriate, or how, as visitors, you can be more culturally appropriate. Again, I really want to applaud you for bringing this up, because it is really important that we look at how do we do things differently, so that it's meaningful for the families and the patients that we're serving. Thank you.
Thank you very much, Sharon. It's good to be here. I'm going to see if I can see the screen, because I can't see it very well, but that's okay. I'm going to talk a little bit about some of the reflections from a physician's perspective. And issues related to end-of-life care in South Asian population. Of course, when we talk about sort of ethical issues that are related to the care of someone, at the end of life, we're talking about that part of life where the person is potentially about to die and they're going to end their life. And that time frame varies according to what definition you look at. But I'm not gonna talk about all of these things that I've listed. Of course, I know that in your program you have some time where you're gonna talk about some of these things in detail, but these are some of the issues that are very prevalent amongst the Southeast Asian population, especially things like medical assistance in dying or physician assistance in dying. That's a very hot topic that's coming up. We need to understand that when we talk about the end-of-life issues in the South Asian population, there is a difference between what culture tells us and what culture they come from and what the religion tells them. And also sometimes there's a tension between the culture and the religion itself. There are also different definitions of death depending on which sect that we're talking about in the South Asian population. Is it brain death or is it heart death? That's important, okay? Because the medical profession, defines it differently sometimes to the way the religion may define it or the culture may define it, okay? What happens in the intensive care units and how do we talk about the dying person in an ICU setting? The whole area of do not resuscitate or do not attempt resuscitation sometimes is interpreted as if I say do not resuscitate, it means that nobody's going to do anything for me. It means do not treat, and sometimes that's where attention comes. And palliative care, I think, is often interpreted as just doing nothing. It means that you're at the end and nothing's going to happen and people are just going to leave you to die. That's kind of some of the things that we face. I don't know why this is not projecting very well, but it's supposed to say why is it important, okay? It's important, of course, because as you heard from Kelly, we're all going to die. That's the good news, and we also know that about 71% of Canadians actually die in a hospital. 58% die in an acute care hospital. And so the numbers are quite high. And an average Canadian spends about 14 of their final 30 days of life in a hospital. So when you look at this, you understand that the environment where these conversations sometimes take place are in the context of an environment with healthcare professionals and other physicians and so on and so forth, right? So it becomes a very interesting dynamic when you look at it. If you look at the modern Western world, an increasing number of people now want to have control on how they die, when they die, and where they die. And that's something that's changing, especially for this population. And even for this population now, many of them will not want to just be kept alive on machines, right? This is a difference. This is a paradigm shift from what you will see sometimes in the South Asian countries and what you see here as the generations of South Asians are getting older in Canada. And what's really important is to understand that there is a real struggle between distinguishing about prolonging life and prolonging death. Physicians and healthcare professionals love to talk about the quality of life, right? I'm here to make your quality of life better. This is my goal. If you ask a physician, you ask a healthcare professional, say, I want to make the quality of life of my patient better. What we don't talk about enough is how do I make the quality of death of my person, my individual, my patient better. And that's the conversation sometimes that we find difficult having. Now I just want to talk a little bit about Islamic ethics, only separately because it's an area of my interest, but also in the South Asian population, there are some major differences in Islamic ethics when you look at other religions, right? So in Islamic ethics, the sanctity of life is a very key principle in Islamic ethics. And this is a quotation from the Quran, who he slays any one man, it shall be as though he has slain mankind as a whole, and he who saves a human life, it's as though he has, saved mankind as a whole. It becomes a very interesting thing when you start talking about physician-assisted dying, right? Or, physician assistance in dying, which is obviously something that's quite a hot topic. In Islamic ethics, God is the arbitrator of the beginning and the end of life, and every moment of life in Islam is precious, right? And therefore, it is our duty, even as healthcare professionals, it is the duty of the healthcare professional to prevent illness, to seek out treatment for illness, to preserve life, and to prolong life. This is a very important thing in Islamic ethics. Prolonging life takes precedence over preserving quality of life in Islam. It's very important to understand this. Prolonging life in Islamic ethics takes precedence over quality of life, but of course the principle is not without any limits, and I'll explain that in a minute. So in Islamic ethics, suffering is not necessarily bad. Although the healthcare professionals should try to minimize and to try and relieve suffering as much as possible, but suffering could be a cause for, retribution of your sins, from an Islamic perspective. It may be a trial or test from God. And it may be that you're going through suffering as a process of your own purification, so that when you come in front of God, you are in the most purified state possible. That's the philosophy of Islamic ethics. And then, because of that, sometimes the end-of-life decision conversations become very interesting and very difficult in this particular population. But if you, an area that particularly of interest of mine is the area of, withholding treatment versus withdrawing treatment. It's a very big difference in the philosophy and the approach from withdrawing and withholding treatment. Islam, for example, allows withholding treatment in terminal illness. So it does allow you to do DNR or do not resuscitate and so on and so forth. But it does not allow, in most cases and in most sects, withdrawal of treatment. Once you're on the ventilator, you can't pull the plug, right, in Islamic ethics, right? It's a very difficult conversation in many of the sects. Now, some sects do differ in this in Islam, but in general, that's what you'll find. In the Sikh population, you'll see generally they're open to both withdrawal and withholding treatment. But one that is, I think Jazz mentioned, was very important, that this conversation is a conversation that's inclusive of all the family members, and that discussion takes place in a context of what the family wants. In the Hindu population, palliative and hospice care are really well aligned with Hindu values. And, the Hindu religion does not, feel that, death should not be sought or prolonged. But spiritual suffering is definitely connected to karma. And what the Hindu religion says sometimes is that enduring physical suffering at the end of life may actually reverse bad karma. Right? So we need to understand, that. Now, once again, having said this from the religious perspective, cultural realities are different, right? And depends on which culture you come from, it may actually coincide with what even the religion thinks. And that's a lot of area where there's tension amongst the South Asian population, okay? The other major area of tension, thanks Sharon, the other major area of tension is around hydration towards the end of life, right? This is a big, big area, right? If you have a person who is at the end of their life let's say in a long-term care facility or somewhere, the fact that they've stopped eating and drinking, right? This becomes a major issue for this population. They don't want people to die thirsty or hungry. So they want to send them to hospital to get intravenous hydration. And we know from palliative care, for example, at the end of life, hydration may actually be worse for that particular person because it increases respiratory secretions and so on and so forth. It actually may lead to more harm than good. And like I said, the whole area of palliative care is not understood very well. People force us, why can we not give them intravenous hydration? Just give them fluid. We can't let them die thirsty. And that's a real problem. And I just want to end now with a word about the healthcare professional, right? The healthcare professional, who is looking after the patient also comes with their own values and beliefs. And sometimes their values and beliefs actually contradict with those of the patient and the families. And it's very difficult for that healthcare professional then to have conversations regarding end of life, because what they believe in and what their values are may be very different from what the patient and their families believe in and what their values are. And the other thing that comes into play is the personal experiences of the healthcare professional. Healthcare professional may have already experienced a person in their own family who has gone through the dying process, and they have their own preconceived ideas and notions about it. And so trying to have that conversation once you've had that experience is very, very difficult. And finally, we have to appreciate and understand that the healthcare professionals who are having these conversations with people who are dying also have a major impact on their own personalities and on their own mental health and on their own mental well-being. And a lot of them suffer from secondary trauma or vicarious trauma because of the fact that they have difficulty in dealing with a dying person on a day-to-day basis. That in turn has a huge effect on the conversations that they have with their family members. So that's kind of a physician's perspective and reflection as far as how we deal with this population in the environments that we care for them. Thank you very much.
Thank you very much, Dr. Mithani. Does anybody have any quick questions before we move on? Just state your name. We've just got time for probably 2 questions.
Yeah. Thank you very much, Doctor, for that fine presentation. My name is Al. We look upon doctors as being near gods at a stage where we're all vulnerable. And your final point is that, yes, physicians do have traumas, but those of us who have faced the loss of a loved one often confront the issue of, doctor, all I want is to give my loved one a fighting chance. Not the silver bullet, just a fighting chance. But yet you look upon the cost of medical care. Your clinical approach to the issue of dying that is so daily is sometimes very frustrating to those of us who view upon this as being a very novel and a very final affair. Thank you.
Any comments, or just leave that there?
I couldn't agree with you more. I actually don't think that, I think physicians are sometimes not well equipped, to have these sensitive conversations, especially in the context where they do not understand the culture of that person and the religion of that person. I personally don't think it's a responsibility of the physician. Necessarily. I think it's the responsibility of the interdisciplinary team to have that conversation. And sometimes, by default, it falls to the physician. And sometimes what happens is that because other healthcare professionals have real trouble in having these conversations, partly because maybe they're not trained to do it, it eventually ends up falling in the hands of the physician. And the physician is sort of told, well, you're the MRP, you're the most responsible person for this patient, you should be having this discussion, not me. And I don't think that's right. I think that it's a collective discussion that needs to happen. But education at every level is important, and I couldn't disagree with you. I couldn't agree with you more.
All right, I'm just going to take one more question. I see other people lined up. I would encourage you, if you can, to wait until the end and see how we're doing for time, and you can probably ask your question then, okay? But just to keep on time. So, sorry.
Thank you, Akbar. So you mentioned the fact that healthcare providers often want to treat end of life or do palliative care in a way that the family and the patient do not agree on. And of course, one way in my culture to get around that is to do personal planning, to have advance directives, to have representation agreements, so that there won't be or shouldn't be any conflict between the healthcare provider and the patient. Are there any cultural beliefs that work against advanced care planning happening in the South Asian community?
Yeah, I think that's a very astute observation. I think that from the religious perspective, I think there is encouragement to talk about the dying process and death. I think most of the religions, whether you look at Sikhism, Hinduism, Islam, when I'm looking at the South Asian population, do encourage having that that discussion way in advance of the dying process, because most of this religion talk about a life after death, right? And this being just a journey, right? It's a temporary journey, right? The tension comes when that actually collides with cultural realities. Culturally, I think that the South Asian population find it difficult to have this conversation. I think one of the points that Kelly made earlier was that it almost sometimes feels that if I talk about it, it means I'm going to die. Right? And so it's better not to talk about it. And I get challenged a lot saying, well, why do you want to talk about this? Like, I'm fine right now. I just have diabetes, high blood pressure, coronary artery disease, but I'm okay, and I've got lots of time left, right? I am finding, however, the younger population who have grown up here, who have been born here, are much more open to having these conversations early than the older population, right? So I think in maybe 10, 20 years, I think the dynamics will change.
Jazz, did you want to say something?
And so I think the other part is that as we do campaigns around advanced care planning and directives, it's important to do culturally sensitive ones. I know at Fraser Health I was involved in one where we did one in Punjabi, and that was really well received. And so as we talk more about this, I think it becomes more of a norm. And right now, you're right, when I tried doing mine, my parents thought I was crazy. So I was like, well, you're so young, why would you want to do this? But anyways, yeah, so it's about having those conversations, and as we do education in the communities for the larger population, it's important to do it for the Pacific cultures as well.
Marvelous, thank you very much. Okay, so we'll move on then to Joyce.
So this morning I'm going to share with you some findings from a fellowship project that I completed last year, and that project focused on care for the older Chinese-speaking families, ill person as well as family, and these individuals will be living with life-limiting illnesses. In this presentation, I'm just going to glean and highlight the insights from the interviews with the family caregivers, as well as focus group that we conducted with healthcare professionals on the topic of communicating care in end of life. Good news, Canadian seniors are living longer and healthier. However, for the older adults, we are seeing more complex health challenges and care needs arising from their chronic life-limiting illnesses. Now, for people who are non-English speaking and have different expectations of the healthcare system, it's conceivable that such barriers would further compromise the ill person's care experience as well as that of the family caregivers. With an increasingly diverse Canadian population, having insights to the care experience of the culturally diverse older adults living with life-limiting illnesses and also that of the families will be critical in the provision of person-centered care in end of life. From the interviews with 6 family caregivers caring for their ill parents, either living at home or in care homes, communication with healthcare professionals was one of the key themes that emerged from the qualitative findings. Some of the issues raised regarding communications were language barrier, dignity and consistent care, responsiveness of the healthcare professional and the care system. For the older adults lacking English skill to communicate in their care environment, misunderstanding between the care recipient and the healthcare providers could arise. Some miscommunication would be a source of frustration for the ill person and also for the family caregivers when the care needs could not be communicated and remain unmet. On the challenges her mother encountered in the care home, a family caregiver said, I'm going to read out the quote, it may be hard to read from the back. Some of the people, the staff as in, they do not know what she, as in mom, wants. She lies on the bed and wanted someone to reposition her. She pressed the call bell button to ask for help. Probably they both could not communicate. And they just told her to fan gao, which is sleep in Cantonese. They can only say these words, the Caucasians or Filipinos or Indians. They just told her to sleep. They always tell me to sleep, but I just want them to straighten my body on the bed. They can't communicate. At times, my mother said she wanted to go to the washroom. They don't know that too. My mother does not know English at all. So, to these Chinese elderly or patients, the support is not enough. Preserving the dignity of the ill persons is deemed foundational in compassionate care. For the culturally diverse ill person and families, the expectation of care that upholds dignity may differ from the healthcare provider's translation of good care. Now, this is illustrated in a family caregiver's response to a situation where he found his elderly father living in a care home wearing pants with the back seams unstitched. So that's what he said. They said that in using the pants with openings, when they are changing diapers, they could save much time. This is something I cannot accept. This is something I cannot accept. Like, I feel that I can appreciate they give assistance to my father, but the problem is, because you want to do this, and so wanting him to wear such pants, I feel that I cannot accept it. If he wears it here, I will accept. But on days he needs to be out for dialysis, please don't ask him to wear such pants. And he still needs to be transferred between beds. You think about it. Is there any dignity left? In addition to preserving the dignity of the ill person, it is also important to the family caregivers that there is a system of communication among the healthcare professionals where consistent care is provided by a team or practitioner attending to the ill family member. Reflecting on his interaction with the staff in the care home, a family caregiver said of the following: I think the staff here, whether care workers or LPN or RNs, I think they are on shift. All the time they would change. For me, it is impossible for me to tell everyone the same situation. This is impossible. But I discover that often I tell this person and this person remembers. When they change to another person, he or she does not seem to know anything. So I wonder, how does their management communicate? Shouldn't there be a system for them to communicate so that with regards to this matter, everyone can know? At the same time, the family caregivers also identify the importance of care providers and the care system capacity to respond to the ill person's and family's needs as it relates to continuity of care. Now, expressing her appreciation for the support she has received from staff in the care home, a caregiver commented, the manner they have the social worker and all. The social worker helped me a lot personally. With such a big family, there must be a lot of argument. They say that I can't listen to too many people's opinion. They see that my mother is very close to me. So they said, in order to make things run smoothly, I can get the power of attorney. Actually, the government did very well. They have the social workers, they have the nurses and all. So everything is very well done in the manner. And we have already heard what the family caregiver said. Now let's look at what the healthcare professionals in the focus group say about their role in providing care for the older adults from culturally diverse population. I've conducted 2 focus groups with interdisciplinary healthcare professionals from diverse care settings. On the topic of their role, the following themes were identified. Flexible role of the care provider in bridging language and cultural barriers, providing consistent care regardless of the care provider's language skill, care providers' awareness of their own assumptions and beliefs. To help bridge the language barrier and to facilitate cross-cultural communication between care providers and recipients, the flexibility of the healthcare professionals to also assume the role of a care navigator was noted to be an important consideration in caring for the vulnerable population, such as older adults who can't speak English. So one practitioner said, even for kids that are in translation from children's care to adult care, things like that, and just around the whole chronic illness model and advanced disease. And I wonder if there isn't a role for, especially with a more vulnerable population that can't speak the language, that are really, transiting from one big system to another, about the role of navigators, which we don't have in our Canadian system. In the focus group, consistency in care provision was also highlighted by the practitioner as critical when caring for the culturally diverse older adults living with life-limiting illnesses. Regardless of whether a common language is shared, the capacity of the healthcare professionals to provide consistent care allows the therapeutic relationships to be established as articulated by the care provider. Because I actually found the most meaningful experiences I have in the community looking after those who are palliative or end-of-life care have been other people who don't speak English. And I found that because I was able to offer, consistent care, even though I didn't speak their language, we have really good rapport. In seeking to provide person-centered care, it is necessary that healthcare professionals have awareness of their own assumptions and beliefs, recognizing that their process of assessment and decision-making is influenced by their values, as the healthcare providers highlighted. So, I think broadly speaking, in terms of cultural diversity and what I see a lot in the community, is the different explanatory models of illness, of specific illness, and of different expectation of care and views regarding death. So a lot of it stems from looking at our process of assessment and our intervention because we make decisions based upon our own assumptions and beliefs. And a lot of that stems from the palliative approach, is based on our Western beliefs. I think we need to be a little bit more self-aware that when we apply that approach, when we work with families. Summing up the key learnings from conversations with families as well as healthcare providers on communicating care in end of life, it is important to clarify the ill person's and family's wishes and hopes in living with life-limiting illnesses. While health-seeking behavior is influenced by the individual cultures, it is essential to be cognizant that there are other personal factors that affect the ill person's and family's interaction with the healthcare professionals and the care system. To provide care that matters to those who received it, it would be necessary to engage both the ill person and the family caregivers, consulting and collaborating as partners in research and in the provision of care. I know I've run out of time, but I have to say this, that I want to thank, first of all, the Canadian Frailty Network for sponsoring my fellowship project. I want to thank the members of iPanel, which is the Initiative for Palliative Approach in Nursing, Evidence and Leadership, for the support rendered throughout the fellowship. I'm especially grateful to my fellowship supervisor, Dr. Ray Sawarski at Trinity Western University, and my interdisciplinary mentor, Dr. Kelly Stadihart at University of Victoria, for their dedicated mentorship over these 2 years of the fellowship. And thank you for joining me in this presentation. I look forward to hearing your thoughts on what resonates with you from my sharing, from your experience as a family caregiver or as a healthcare professional. Thank you.
Hello, good afternoon. Thank you, Sharon, for your invitation. It's my privilege to join this panel to share with you my experiences on end-of-life conversations with Chinese Canadian clients in long-term care setting. So just let's start with the context of my experiences. My experiences were linked to a research project on integration of palliative approach by iPanel at the residential care unit of Mount St. Joseph Hospital. Mount St. Joseph Hospital was built in 1946 by the missionary sisters of the Immaculate Conception to provide health and education services primarily to the Asian community. Our care is guided by the Eden philosophy and the missions and values of Providence Healthcare that are driven by compassion and social justice. The residential care unit provides home for 99 elders who require 24/7 nursing care, mostly function at extended care level. Over 90% of them are Chinese immigrants from Hong Kong or mainland China. Their age range is about 60 to 100. Majority of them speak Cantonese, some speak Mandarin and other Chinese dialects. Before coming to our unit, many of them had lived with families until their care needs could not be met at their home. End-of-life conversations are mostly challenging, particularly with complex cultural contexts. Here are some factors identified from my experiences, but they do not represent all Chinese. One aspect is life experiences. My client population, who has experienced war times and immigration, can have complex life experiences and particular coping strategies. Another aspect is cultural belief on medicine. Traditional Chinese medicine believes in yin-yang theory, and Western medicine is believed to be too strong. This concept is particularly strong for clients who have seldom used Western medicine or lack of knowledge about it. Cultural values are often complex, particularly with families of immigrants and with different generations. Traditional values such as keeping family problems confidential to save reputation and identity of the family. Gender roles, for example, the eldest male is the most responsible person and decision maker of the family. Filial piety is one of the most important virtues in Chinese culture. Within this notion, there is a prescribed set of rules of obligations, duties, and behaviors amongst family members based on a hierarchy of age and gender. Concept of death and dying is influenced by traditional doctrines such as Confucianism. Different religious beliefs are superstition, for example, belief that talking about death will attract bad spirits and will speed up death. I have created a scenario that captures a few of my learning experience for purpose of illustrating what I have mentioned above. Mrs. Chan, 90 years old, immigrated from China 40 years ago, had lived with 92-year-old husband and daughter in Vancouver. The elder couple was illiterate and spoke Cantonese only. Her daughter worked long hours in restaurant. She had a married daughter who spoke only English. Mrs. Chan moved to our unit after discharge from acute care hospital. She had repeated stroke and multiple serious medical problems. She was cognitively impaired with minimal verbal responses. There was a gradual decline in her general condition. She was expected to have less than 6 months to live. The following steps were taken for goals of care conversations. First of all, check our own readiness. That is, what do we know about Mrs. Chan? Then check for the readiness of Mrs. Chan and the family. So what do they know about the medical condition of Mrs. Chan? What are their hopes and expectations? From there, we explore opportunity and space to discuss end-of-life issues. Using the 4 boxes ethical grid, we gathered and clarified facts on the 4 aspects to support ongoing end-of-life conversations. They were the aspects of medical conditions, preferences of Mrs. Chan, quality of life, and contextual factors for decision-making. We had ongoing conversations with families since Mrs. Chan moved in. Here are what we've learned and outcomes. At the beginning, families did not think Mrs. Chan was at the end of life. They believed she would survive given her strong will and wanted to prolong her life. Factors related to life experience and cultural family values were identified. Mrs. Chan had survived through many hardships and critical conditions. Her last wish was to reunite with her separated son in China for a complete family. In response, we asked families to describe the understanding of Mrs. Chan's health status. Then we explained her medical conditions, care options, and limitations. We issued a letter to explain the conditions of Mrs. Chan to assist with visa application of her son. Mr. Chen visited daily for long hours despite of own health issues. He had required emergency medical intervention during one visit. Daughter also visited late daily after work. In this situation, cultural family values, filial piety, and obligations were reflected. Families felt guilty of not able to appreciate the sacrifice of Mrs. Chen, who dedicated all of herself to the family. They felt obligated to ensure all needs of Mrs. Chen were met. In response, we explored family and healthcare resources to support Mr. Chen with his healthcare and psychological needs. We also discussed how our care team can work with the family to address the needs. Families fed Mrs. Chen with food texture against our recommendation that might risk her choking or aspiration. The actions were related to life experiences. Mrs. Chen has suffered from wars and starvation. Families wanted her to enjoy food and avoid death from starvation. It gave them a sense of relief and hope when Mrs. Chen ate better. We acknowledged the wish to enhance the quality of life of Mrs. Chen, explained the risks of the actions and strategies to reduce risk. Mrs. Chen appeared in distress at times. Doctors ordered narcotics for pain management, but families declined. The decision was influenced by cultural belief on medicine and previous experiences. Mrs. Chen had bad experience in hospital attributed to use of narcotics. Families worried that narcotics were too strong and would cause harm. They believed the sedative effect of narcotics would impact Mrs. Chan's oral intake and interactions with families. They asked about permission to use traditional Chinese medicine. In response, we clarified the use of narcotics and discussed options for pain management. When end of life was imminent, daughter insisted maximum life support, but Mr. Chen declined blood work for his wife. This reflected traditional gender roles and coping mechanisms. Families realized that Mrs. Chen was dying. They drew on different life experiences, values, and beliefs to cope with the situation. There was contradiction in thoughts between Mr. Chen and his daughter. We discussed reason for blood work in relation to the request for maximum life support. Mr. Chen felt very guilty to witness his wife suffering from aggressive treatment and agreed to palliative care. His daughter disagreed, but respected the decision of her father. We supported Mrs. Chen to connect with his son in China using electronic media. At the end, Mrs. Chen passed away with a company of her families. We supported families in fulfilling their cultural roles and religious practices for her death. Her son did not get to visit her before her death, but was able to attend her funeral. So here are some identified barriers, and it's alluded to many of our speakers who have spoken earlier. Time. Time is of essence to gather information and clarify facts with clients. Emotions and responses to end of life often affect the readiness for conversations. Assumptions, beliefs, and values of care providers versus that of clients often pose barriers. Relationship and trust building is affected by many cultural factors and contextual factors. Support available often affects the end of life experiences and decision making. Here are some strategies we use to minimize barriers. Caring, being mindful about the client and family in context. Understanding, being relational and compassionate. Respectful, respect cultural belief and rituals. Informative, provide information to support clients on decision making. Observant, mindful about nonverbal cues as feedback to conversations. Unbiased, being non-judgmental and aware about our own values. Supportive, support the strengths and coping mechanisms of clients facing end of life. To conclude, we learned that end of life is a family experience. It is important to address the needs of clients and their families as one entity and in relation to their contextual situations. There is no one recipe that contributes to success for all conversations. The perspectives, expectations, and goals of clients constantly evolve from the clinical conditions and experiences. It requires a team approach and ongoing conversation in a fluid manner, keeping in mind the barriers, tiers, and strategies curious within conversations. Thank you.
I have to commend Felicia because she said that her talk was going to be 11 minutes and it was actually not less than 10. So well done. Now, the two of you, and sorry, Joyce, my apologies, I got your last name wrong the first time, Joyce Lee. So the two of you wanted to field questions together. So we do have time to field a couple of questions. If you have any, please scurry up to the mic. There we are, scurrying.
I'm scurrying.
Thank you.
I certainly enjoyed both conversations, all of them really. But you were referring to the Chinese Asian community. I have to tell you, all those limitations, those restrictions, they apply to everybody. That's right.
Yeah.
Thank you.
We're all human. Isn't that lovely to know?
Go ahead.
Well, thank you very much. Actually, that is right at the back of my mind as in the papers when you're going to write up, we have to be able to address. When we talk about culture, firstly, I want to also reiterate what Jess says about there is no one culture group that represents all. Even there is diversity within Chinese, diversity within Asian, Indians, or any other culture group. And all these challenges or some of the limitations that has been highlighted in my studies I'm talking about is that it does apply to those who have an issues when they are new to a country, when there is challenges with the tension with the care system within that mainstream. So regardless of whether you're Chinese or whether you're, as long as there is this language barriers that highlights that now I have a greater barriers because I don't speak the language. So it illuminates. But other than that, people do face these challenges that we talked about.
All right, we have another question?
I was just curious, you said the yin-yang theory was in opposition to traditional medicine. I just wonder if you could give a couple of examples of that so we understand what it is you're talking about. And I have a second question that's also an either-or. Is palliative care necessarily in opposition to life support and things like that?
So about the first question on traditional Chinese, on the yin-yang theory. Traditional Chinese medicine has been used in China for over thousands of years, and there is a particular theory about what kind of food is yin and what kind of food is yang. So they believe that there has to be a balance between the two of them and you're healthy. So when they believe like illness is an imbalance between the two forces. So that, like, if there is illness, you go to see a traditional Chinese doctor, then they will try to say, okay, you are too yin or you're too yang. So they will give you some herbs that going to balance between the two. And so they do not have such in Western medicine. And the second question is about whether or not there is enough resources to do palliative care.
No, it seemed like what I was hearing, and I'm not sure if that was intended, that it was a choice between sort of doing life support or palliative care. And I'm, like, is there a fine line, or is that a decision, or can you do both at the same time?
So in a long-term care setting, when the resident moved in, that's most important is to start the conversation as early as possible. So it depends on the clinical condition and the fourth aspect that I have mentioned earlier. So some may need like more life support in a sense if they are not actually in a imminent status of death. But some actually prefer they are knowing that this is what they want. Some they may have, the very few in the Chinese population have advanced care, options of care being decided, but if that is what they want, then we will explore the palliative care for them. Yeah.
Thank you.
All right, thank you. Okay. Hanif, yeah.
Thanks. This is just in response to, or just a comment about Joyce's presentation in terms of this delivery of culturally competent and consistent care, that one of the critical factors that faces nurses and other healthcare providers within the healthcare system is inadequate staffing. So it's not that it precludes the provision of culturally competent or sensitive care, but that is a critical factor that I think cannot be underplayed.
All right. Anybody want to comment on that, or just leave it as a comment?
Okay. Thank you again for that observation. When the examples that one of the family caregivers says about that system of communication, indeed, it illuminates that staff is shorthanded. They are doing a lot more than the people available. And it wasn't quite presented here, but a suggestion that actually this family caregiver provides is that, can there be a little more flexibility? Can this person doing this and not just restricted to that particular scope of work, but if you realize that someone having language issues, can the person kind of step in to be able to provide that gap? A little bit of that navigation role into that, and actually the care navigator's role, not a formal role, but also being able to step in to help that person to navigate some of these challenges. But I do hear about there is indeed an issue with short-handedness in terms of the care facilities.
I just want to add that, within the whole conversations of goals of care and end of life, it has to, as I mentioned, it's like a team approach. So everyone who have a chance to interact with the person or the family will have a chance to make a difference to the decision and giving them information and resources of how to handle the situations.
Okay. All right. Let's, we'll take two more quick questions, please.
Okay, quick question. So for me, dying it takes the community to help. It's the doctors, it's the families, people that help you around. And I think we are relying too much in the health system to help people to die, and we think the doctors are the ones who can have all the power to make sure that people don't die. But I think it's family, and the most important is have the support, the emotional support of this person to die. And who can do better than the family, the people that speak your language, the people that understand and know you for so long that and this is what they need. They need the support to help them to go and get out of this world. But yeah, we should, I don't know, for my point of view, I think it's a community responsibility, and it's not too much rely on this health system, but everybody in the community.
Yes, it's true. It's everyone the most important thing is to know the person, to know the family. And one thing I just want to mention is the challenge of frontline healthcare workers or frontline healthcare professionals is actually to know the families and to know the clients, because knowing about the social background and the contextual situation, all that, it involves a lot of the time. And with our client populations, many of the times they have multiple medical experiences, and how they're being communicated to us. Like, how do each individual coming to work instead of focusing on a task, but then knowing the person is the major challenge.
I'd just like to add on to that. Indeed, when you talk about the community of care, who is the main person in the community? The family caregivers, those who are closest. So when you're providing care, it is not just the ill person that is the care recipient. It is also the family caregiver, not only as a recipient of that support, but also a provider. So therefore, you have this whole team. You have this collaboration between the professionals and the families, collaborative, working together to be able to support a person in the dying trajectory.
These are important comments, but I can't resist but say that as much as this is true, not everybody has family members, and not all family members get along. So, yeah, to underscore Kelly's earlier point. So we have to remember that too. Okay, just one more question, please. I'm sorry if you're waiting. We'll leave it to the end. Hopefully we'll have some time at the very end.
Thank you very much. The more I'm listening to the variety of points that are being made, the more I think of the fact that the universality, which was referred to by a previous speaker, is beginning to emerge. What bothers me more than anything else, that despite the fact that we all can agree on the fact that a team approach is necessary, that communication is necessary, the resources are not available primarily because of the political lack of will and pressure from society at large to deal with this. How do you suggest we begin to do that? Thank you.
Ooh. Go ahead. Okay, very quickly, because we do need to move on to our next speaker. Yeah.
I'm not a politician, so I cannot speak from that. Political will. How do you make that? If I could have an illustration, I recall with iPanel that Kelly is part of, what has been happening is with these network, to be able to bring issues to the House, to be able to talk and to have conversation, to raise awareness, to put a little dent. Changes do not happen overnight. Changes happen with little by little, that step process, but persistency, consistency, involving people, community, such as when you're here. So how do we make changes to politicians? Keep talking. How long? Don't know. Keep talking, and then we'll see changes.
All right.
And I think like story matters. Yeah.
Yes. And as Gloria makes her way up to the podium, Akbar would like to say one final.
I just want to say something. You know, it's always easy to say that we don't have enough resources, and the reality is we don't. You know, but it's important to understand that what we have to do is to look at how we can use the resources we have differently. And I think we haven't put enough time in how we can use our resources differently, and how we can decentralize acute care and giving enough resources to community care so that there's not a lot of pressure in acute care. And I think that's where the political will needs to change, because we'll never have enough resources. I'll tell you, it'll never be enough, but we should be able to use it differently.
Thank you. And over to Dr. Gloria Gutman to close the session.
Thank you. A number of you have heard me talk before and make the point that seniors are not a homogeneous group. And certainly the speakers before me have made it clear that there are differences within the ethnic communities, and that not all Muslims are alike or not all Sikhs are alike, and we need to keep remembering that kind of thing. I'm going to talk about a different kind of diversity, one that cuts across ethnicities and cuts across religions, and that is the LGBT community. And how I began to study and to work with this community goes back to about 3 Friesen conferences ago. Some of you would have been at the one, and you can raise your hands if you were, called Taboo Topics in Long-Term Care, or in Residential Care. And, you know, in the days when we first began to build care facilities in this province, we used to talk about the problems of couples coming in, and he was put on one side, she was put on the other, and they were not supposed to mix. Or about older men and women who, in the context of a care facility, found each other and had some kind of romantic engagement, and their children had a fit. Well, as I began talking with my colleagues in continuing care, what they said to me was there's another whole group we really do need to think about, and that is the LGBT community, many of whom never thought they would live to be old. And one of the great success stories is the retroviral therapy that has allowed people with AIDS to live to be old. And so we began a project a couple of years ago with the same funding agency, the Frailty Network, only at that time it was called the Technology Evaluation for the Elderly. It's now called Canadian Frailty Network. But they funded us to do a study that had 3 parts to it. We did focus groups with LGBT older adults and service providers nationally, Vancouver, Edmonton, Toronto, Montreal, and Halifax. We wanted to understand the issues and the extent to which those who never thought they would live to be old had done any end-of-life planning.
from our findings, we did a series of town halls in these same communities at which we fed back our information. We also developed what we call resource inventories. And if you go to our website, which you'll see there, you will find that for each of the 5 cities, and in our case provincially, we have an inventory of services for older adults for late life, but they are categorized in terms of the degree to which they are LGBT friendly. Because many places will say we serve all, but when they say we serve all, what that means is you better fit into the heteronormative pattern, right? If you're a little different, a little odd, and you don't fit, that's your problem, and they may not be welcoming to you. And the third piece of our project was to put together a web-based platform. Originally, we talked about it as being a demonstration and as a proof of concept. In fact, it's a roaring success in terms of people accessing the information that we posted there. So we did something that was a little different in that we specifically wanted to, and I'm the new kid in this area of research, so I kept asking the questions, what are the differences between gay and bisexual men, between lesbians, between transgender people? Again, they're not homogeneous groups. And so we did interviews with them, and very much we found that there are some commonalities across groups, but we also found some substantial differences. This is our sample. It ranged in age from 55 to 89. And we also had a group of service providers that we interviewed, but this is the LGBT sample. And you know, the LGBT population faced the same kinds of issues as everybody else, plus there's other things layered on top. So many of the people who are old today lived through the period when they were considered to be insane or they were considered to be criminals. So they've got all of that baggage. They need to rely on families of choice for care and support, because what the international literature is showing and the statistics and what we found in our studies is that there are considerably fewer within the LGBT community who have families, who are married, who have the support systems. You know, you've all been talking about involving the family. What happens if you don't have a family? See, and that again raised an interesting question for me, because I wanted to know, is it because they're LGBT and have no family, or do some of these lessons apply to anybody who doesn't have a family? And you know, we've got more and more people than ever before who are choosing not to get married or not to partner, and who say, you know, we did studies with older women who said, I did all those things for my family. You get married again? Are you nuts? They said, you know, and we phrased that project as it's my turn now. I want to do what I want to do when I want to do it. So if you look at this at this particular slide, you can see of the gay men, 62% were single, 72% lived alone, 77% had no kids, and 32% couldn't think of who would look after them if they were old and frail. And so a number of the themes that came through are on this slide. A major one was that cut across all 3 groups, there'll be nobody there. Who's going to look after me? Or saying, you know, we have friends, but I don't want to saddle them with my problems. And the transgender people of saying, you know, even within the LGBT community, they're not popular. So they have a problem of who's going to look after me. It was interesting that within the lesbian community, they spoke up. They were a very active group and said, you know, the government should be doing more for us. The transgender people said, boy, you've got to have a thick skin. And those people have to be very tough to do their thing in the face of discrimination that cuts across. Again, if you'll go out in the hall and you'll see posters of mine from another project where we see that again, people of different color, of different religions, different styles, do different things, but all of which may well be abused older people. So many of these people said that they were very concerned about having to go, if they went into a care facility, having to go back in the closet. For two reasons. One, because there may be staff who don't know how to be respectful or how to meet their needs. The other is sometimes the other people in the facility. You know, just because you get to be old doesn't mean you're nice. So they all said very clearly that there's a need for education about LGBT issues, both within the LGBT community and within the broader community. Ageism is alive and well in the gay male community. But it was interesting when we asked what planning they had done. In all three groups, what you see is that about 2/3 had a will. So the message had got through about what to do with your assets. But a far smaller percent had done anything about making some representation agreement, and you'll see very small percentages, and that cuts across the heteronormative population as well. Many of you in this room probably don't have a representation agreement. Am I right? So in terms of policy implications, certainly one size will not fit all. And it's important not to homogenize the older adult population or within it the subgroups. We need to recognize differences and the legacy of HIV. Many of those people, especially gay men, who are living now with HIV. So it's interesting. It used to be living with HIV, and now it's considering the whole issue of dying with HIV and dying with dignity. But with all of, as they get old, the various comorbidities. And I heard one fellow say, he says, it's harder to manage my diabetes than it is to manage my HIV. Right? So we certainly need to attend to staff education. We need to foster and facilitate advanced care planning and to find out if the various documents are in fact applicable to different groups, because many of them will talk about, wives and husbands, but they don't talk about partners. So we also need to recognize and support innovation, and as Casey and Kyle said, we invent family. We may not have biological family, but we have befriended, financed, educated other people. We have created family, and it's really, really important that the healthcare providers recognize those family and recognize the people that are significant others, even if they're not legally married. And yes, LGBT people now can get legally married, but not all of them, and especially not the older people. Thank you.
Thank you very much, Gloria. So we are starting our lunch at 12:15. That means that we have 3 minutes for questions. And so if you don't want people to get on your back, then make them short, please. Thank you.
I would like to thank Dr. Mitani for differentiating culture from religious tradition. But I also would like to share with you my nightmare. It will be being in a Catholic hospital, having South Asian doctor and Chinese nurse. Because then the biases will be layered, and some judgment will be applied to my particular situation. Like, I was born in Poland, but I'm practicing Buddhist. Where would I fit with this kind of a scenario? And I don't have friends, I'm a single person, so I wouldn't have 16 members of family.
This is the reality. I think the reality that you're facing is important to understand, and I think it goes back down to what I said about how healthcare professionals come with their own values, and they come with their own teachings, and they come with their own religions, and they come with their own experiences, and so. Having that conversation with somebody like you from Poland who's a practicing Buddhist is very challenging for the healthcare professional. Yeah. Make sure you have that living will, but I think it's very challenging to have those conversations. And I think that what's important is to make sure that, we do not take that judgmental sort of approach that we tend to take. Physicians are, and I say that respectfully to my physician colleagues, they're notorious, right, to be in an authoritative decision-making position where they're very quick to make judgments. Sometimes those judgments are based on their own personal value systems. They have nothing to do with clinical care. If you are really a proponent of patient-focused care or resident-focused care or whatever it is, then I think you need to take time to appreciate and understand that particular person and what that person's own cultural and religious norms are, to be able to help and nurture that person to make their decisions, which is right for them, right, and not impose your values on them. It's a challenge. It's tough, but it is a challenge.
I just want to say to my students, intersections of identity. Yes. Okay. Next question.
So we're short of time, and I just want to put out the whole question and issue of navigators. A couple of you have mentioned them. There's the whole world of, you can have professional navigators, but we've already heard that we don't have the resources. We have this commonality that we're all different. So within our multitude of societies, is there already, or could there be, the concept of volunteer navigators within our society? We're aging. I'm in my early 70s. I'm long retired from being a clinical planner, but my friends are dying, and because of my experience, I get involved, maybe providing support, but I'm very unskilled. Are there programs? Could there be programs? Should we think about educating people to be volunteer navigators?
Do you want to speak to that?
Feedback to that? Well, thank you for raising that. In fact, several years ago, BC Cancer Agency, they have a studies on peer navigators, and they have cancer survivors coming up to be able to provide support, sharing their stories, connecting them one-on-one to be able to walk them through the cancer journeys. And the feedback from the cancer patients themselves is that these people understood me. They've been there. They are the best navigators. I think there is a great values to be able to bring in peers into that navigation role. And it's not, when we talk about care navigators, it's not that's just a formalized role that the healthcare professionals take on. Every person who has been part of the journey or be able to connect with the patient will be that navigator.
All right, thank you so much. I would like to suggest that perhaps you speak to Roz Kaplan in the break, because she's got ideas about things like that. Okay, Laura, you're not going to let me get it. People want lunch, dear. Okay, hurry up.
I just wanted to, in reference to Gloria Gutman's presentation, I was speaking with the chair on HIV and aging a couple weeks ago, and he said one of the biggest concerns in terms of the particular aging with HIV block is that people are then more susceptible to chronic ailments earlier on. In fact, prior to them being of an age that then has access to some of the services that would be provided for people with comorbidities or who are already, that sort of standard 65 plus range, but instead you have people with HIV or I was reading the other day as well, people in more remote, let's say rural and First Nations communities who end up encountering those effects of aging a decade or more earlier than the rest of the population. Could you speak to that?
Thank you for pointing that out. That's quite true, that a number of the marginalized groups do experience the indignities of aging at an earlier age, and so we need to be aware of that.